Hold on.
Okay.
We are officially live. It's Dr. Torrance and Dr. Zakas, fellowship trained spine and interventional regenerative specialist. And it should say go live. Okay, press go live. My go live has gone live. We are now live on multiple streams. And if you get any questions, Dr. Zakas, please feed those to me because that's your question and answer bank. I got my question and answer bank. I'm super pumped. We are Regenix at New Regeneration Orthopedics in Florida. I'm coming to you live, and this is the coolest thing about this StreamYard is that we're able to come live to you from different locations. Dr. Zakas is live in Winter Park, Orlando area, and I'm here in St. Petersburg, but together we make up a good part of the group we have. And Dr. Zakas, grateful to have you. How are you doing today?
Thank you. I'm doing real well, Dr. Torrance. How are you, my friend?
I'm doing great. What'd you get into on your week last week? I heard, you were anything fun, anything talk about?
Oh, you mean my week off?
Yeah.
Yeah, I went back to Arizona for a little bit, saw some friends, some people I haven't seen in a very long time.
Okay.
But yeah, it was good. It was really good. Thank you.
Awesome, man. Awesome. Well, I'm pumped. I think this is going to do great. If you see anything pop up. So quite a bit has happened since we last had this conversation. You have become an internet phenomenon, Dr. Zakas. And knee arthritis.
Oh, I have.
You are an internet phenomenon. You are a trusted expert and about knee arthritis. You've gone everything about knee arthritis for regenerative options, bone-on-bone arthritis, whether it's trying to avoid knee replacements. It's fantastic to see that you're doing so well. Wanted to commend you on that. And then also let's talk about your top trending reel was it was rating all the options out there. And one of the options that came up that you talked about was arthrosamid, right?
Yeah.
And that's not even available in the United States.
It's not.
It's really interesting. So tell me more about that and what you've read about it, because I've read a lot about it. I want to see what you've heard.
Yeah, so arthrosamid is basically, it's a polyacrylamide hydrogel. And from what I've read, it actually, when it's injected in the knee one time, it actually sort of kind of weaves its way into the actual synovium of the knee. And it's supposed to be non-resorbable or absorbable. So it's supposed to stay a really long time. And some studies are showing that in certain patients, it can help for 3, sometimes even 4 years. So it's an interesting option. I do wish we had it available in the United States. The reason why I included that and made videos about it is because in some of my earlier videos, some of the viewers were leaving comments asking me to talk about it. Yeah. And so I had no idea even really what it was since it's not available here. So yeah, so I looked it up and I was like, oh, that's really cool. It's an interesting thing. This is not a regenerative treatment. It's still not what we do. It does not address ligaments, tendons, meniscus. It does not address bone marrow lesions. But it seems like it's a viable option for some people. I also found out that in Canada, the cost of the procedure is covered, but the cost of the medication is not.
Wow. Okay.
And so it can still end up, so patients who come from the United States and fly up there can still end up paying like $2,000 or $3,000 out of pocket for it. And, for me, I would still take PRP over it, at least the PRP that we do, a high concentration PRP.
Yep.
Especially if it's around the same price. But ultimately for those patients that have severe knee osteoarthritis, bone-on-bone osteoarthritis, nothing beats the bone augmentation procedure. But yeah, arthrosamid is definitely an interesting thing. I think they would actually have to do an entire phase 3 trial in the US to get approval here. They would not have to repeat phase 1 or 2. And phase 3, as you know, is the most expensive phase by far. And so I don't know if they're willing to shell out that kind of cash to get approved here. There's certainly a market for it. But unfortunately, it doesn't even look like, I looked up on clinicaltrials.gov. There's not a phase 3 trial in the United States planned.
Yeah, I said the same thing. I think, and what I was reading about it, it's best for synovitis. Am I wrong in saying that? Isn't that the indication that it has for when you have inflammation of the synovium? I don't think it really works as great for, obviously bone marrow edema, I don't think it's going to work as well as an interosseous injection, but correct me if I'm wrong. I thought that the synovitis, because it interweaves into the synovium, I thought it actually does pretty well with, knee pain due to synovitis. Am I right?
Yeah. And pretty much all osteoarthritis has some aspect of synovitis to it. Some people's knees like really blow up, obviously, but some people, they kind of just have that low-lying inflammation. So to that end, yes, that is likely how it treats it, but it does seem to give, pretty durable relief for a certain percentage of patients. Like I said, I would love to have it here because it's just like another tool in the toolkit. And I think the more tools we have, the better, because there's no one thing that works for everybody across the board. And you'd have to wonder. It's like, okay, what if we were to combine that with another treatment?
Yeah, right.
Right.
Yeah.
Even as some things work well standalone, and some things work even better when they combine them with other things. So, in the future, if it was approved here, then we could combine that with bone augmentation and with treating the ligaments with PRP and maybe the meniscus with PRP or MFAT. And now we can have a 2 or 3 three-wave treatment, so to speak, for sort of all the things that we see in osteoarthritis.
100%. Love it. Love it. Now, correct me if I'm wrong. That is not the German gel shots, right? Or is it?
No, the German gel shot is actually, I believe it's something called Cardistem, which people ask me about too.
Yes. Yeah.
And Cardistem, and I looked this up as well, obviously not available in the United States. Cardistem is actually like a small plug for like osteochondral defects.
Yeah.
So that is not something that's across the board for knee osteoarthritis. Some people, particularly younger people, can have OCDs or osteochondral defects, which can cause them issues, and it might be effective for those patients. But that is not something for osteoarthritis.
So an osteochondral defect, I'm showing you a knee model here, would usually occur somewhere in the femoral condyle, lateral medial femoral condyle. And there's actually really good indications for less than 2 centimeters. Bone marrow concentrate does fantastic for those. So again, I think that's something where I would use your own biologic versus using what is it called again? I forget the
Cardistem.
Cardistem. But using your body's own cells, the benefit of that is that you don't need 3-phase clinical trials to use your body's own cells to help you get better, right? And that's why what we do is within our space, we use your body's own cells to help your body heal itself. And I think that's a big, big caveat. Everybody's like, oh, it's not FDA approved. Your body's own cells don't need to be approved.
Correct.
They need to be used in the same day in the same surgical type procedure to make sure that you're getting your own cells, and your cells should help your body repair itself. So huge indication there. And that's why I think that everybody gets it's not FDA approved. I'm like, sweetheart, I don't need to be FDA approved to use your body's own cells that came from you, and I concentrate them because it's in the scope of my practice of medicine, because I'm a sports medicine physician. I'm double board certified. That's what I do. And so that's like saying somebody needs to be FDA approved to pull some blood from you to test it. No, they don't need to be FDA approved to do that. They're pulling blood. They're analyzing your blood to test your own blood. So that was a pretty good, I love that question. I get that question a lot about the federal, approval for bone marrow concentrate and stem cells. And so BMAC from your own body is the best place for stem cells that there is in the United States, bar none, and putting it back in the same day. So hopefully it's got that little tidbit and trick there. But,
and the other question related to that, I actually had this today. I had a really nice guy in his mid-70s, and we're going to end up treating his knee and his back. He has severe osteoarthritis. And he's a really, really smart guy. He's one of my favorite patients. He's a cool guy. He's like in there with the phone. He has ChatGPT on his phone. He kind of like asks it things. At our first visit, he actually ChatGPT'd my name. And saw everything that came up, and I guess it told him I was a good doctor or something. So that was pretty interesting. But so I saw him again today, and he had asked me, "Oh, well, someone else or someone online said that my own cells are too old." And I told him to go on my Instagram. I've made a couple of videos about this, and it's true that, when you're in your 70s, your own cells are not as robust as they were in your 50s or 40s. If you're in your 40s, they're not as robust as they were when you were a teenager or 20s. But despite that, Dr. Hernigau's data that's published on knee, as well as sort of his unpublished data that we've seen on hips and shoulders and ankles, he's been doing these for 15, 20 years on people in their 60s, 70s, 80s, and beyond. And so as it stands right now, there's nothing in the United States that heals you better than your own cells, regardless of their age. Your cells have your genetic signature. They will not be rejected by your immune system. Other people's cells, when they're injected into you, once they are somewhat immune privileged at first, but if they differentiate into anything, your immune system will very quickly recognize that and get rid of them. And it's going to have a hard time integrating into your own tissue. So this field is evolving, and allogenic orthobiologics, I think, do have a place in the future. but those have to be, in this country, FDA approved. They have to be studied for 10 years and $1 billion. And, right now we have unbelievably impressive data, 15-year data on bone augmentation from your body's own cells, regardless of whether you're 40 or 80.
Yeah, one of the biggest things I tell patients about using your body's own cells is if you're dealing with a meniscus tear and some arthritis, and that study that just came out that I just posted about yesterday, talking about the 10-year data of doing a knee meniscectomy or a knee clean out procedure. The data is not good, guys. The data shows that at 10 years, there's actually a higher propensity for your knee to go to knee replacement if you had that meniscectomy 10 years ago. So what am I saying? You had a knee scope. New England Journal of Medicine did the first study. It was a 1-year study, and it looked at, okay, was a knee scope with arthritis present, a degenerative meniscus tear, was it better than physical therapy at 1 year out? The answer was no. No. I mean, so that study showed that, okay, it wasn't better than physical therapy. So do physical therapy versus doing a meniscectomy, a clean out procedure. Now, what we're seeing in the 10-year data is even more mind-blowing to me. It's like, don't let yourself go and get a knee scope, a knee clean out, unless you have clicking, locking, popping, some mechanical obstruction. That would be the only indication that I would let my knee get scoped at this point. What about you, Dr. Zakas?
Yeah, absolutely. I would say mechanical locking is probably the only symptom, and significant mechanical locking. It's tomorrow or Friday. I'm going to post a video that asks the question, is your procedure destructive or is it regenerative? And, meniscus clean out surgeries and these sorts of things, cortisone injections, obviously, these are destructive. These are things that might give short-term relief. And in this study, even in a year, it didn't give short-term relief, but at best, it gives short-term relief at the expense of degenerating your cartilage much faster and hastening your need to have a knee replacement or, hopefully a bone augmentation procedure that we do instead of knee replacement. And that's an important thing too, is that a lot of times these degenerative meniscus tears, they typically, there's no acute injury. It's not like a 25-year-old NFL football player tears his meniscus. He has to have acute surgery for that. These are degenerative and they typically precede osteoarthritis. They happen before osteoarthritis. So if you have this and then you have that operated on, you already are more prone to osteoarthritis because of that meniscus tear. And now you're just making it hasten that much faster. And so degenerative meniscus tears can precede osteoarthritis, but everybody who has osteoarthritis is going to have degenerative meniscus tears. But again, if you have the degenerative meniscus tear and not osteoarthritis, that's a great time to intervene with orthobiologic like platelet-rich plasma to both heal your pain and potentially, hopefully, protect that cartilage that you have. Yeah.
I want to, two things I wanted to say there that I always tell patients. After the age of 40, a meniscus tear is like gray hair. Right. Yeah. It is present. There's likely a meniscus tear in your knee. Is it symptomatic or not? That's really becomes the question. We help patients go from symptomatic to asymptomatic and also protect the tissue and make sure that we manage the pain and treat the knee. Right.
Yes.
Now, also, I hope that the second thing I want to mention was I hope you discussed it as anabolic or catabolic, because everybody knows that anabolic steroids, right? They build you up, get you stronger. Regenerative orthopedics is more like the anabolic steroid in a way, is that's helping your body's own cells get stronger and more robust and healthier. So, catabolic is breaking down, right? So catabolic would be more like you're saying, destructive, degenerative, that type of stuff. So I think people know anabolic steroids. I hope you kind of threw that in there. If you didn't, I'm going to steal it from you and I'm going to use it.
Take it. Yeah, take it. I didn't talk about it in that way, but that's another great way to say it for sure. I like that.
Yeah. Yeah, because everybody knows that D-ball, gets the muscles stronger, bro. You got to get up there and get the but
and if I could just say, Dr. Torrance, interesting is that this patient, this is another good point on this. The patient that saw me today, the guy in his 70s, we have him going to be scheduled soon to do a left knee bone augmentation to try and prevent or delay the need for a knee replacement, hopefully ever. And he saw another doctor in town, and the doctor x-rayed both of his knees and said, oh, you should have this done on your right knee as well, because your right knee on x-ray looks just as bad as your left knee. And so he came to me to talk about his right knee today, as well as his low back. And I said to him, well, is your right knee hurting you? And he said, no. And I said, well, then we don't do anything.
Yeah.
And he was kind of shocked. He's like, what's going? And I said, well, no, like if we treat pain, and then the imaging gives us clues as to why you have pain. We don't just treat imaging, because I said there's a lot of people 70s, 80s, 90s who have no cartilage left in their knee, and maybe they probably don't have bone marrow lesions, or they have no significant inflammation, and they don't, and they never will have pain. And so I said to him, well, he was very happy about that. I said, good news, we should not touch your right knee. And he also said that the other doctor said, well, you're having pain in that joint is inevitable. And I strongly disagreed with that. And I said, well, first of all, what a terrible thing to tell somebody, that you're definitely going to have pain. Like, you don't know that. I don't know that. Nobody knows that. No. And so I said, well, if you made it this far without having pain, great. Maybe you'll never have pain in your life. We'll get your back feeling better. We get that left knee feeling better. And if your right knee actually ever causes you pain, well, then you know who to see. So again, we treat patients, and we essentially treat pain, and the imaging helps us figure out why people are in pain, but it does not tell us who has pain and who doesn't.
Yeah, it's a roadmap, right? Imaging,
correct.
we don't treat an image, we treat a patient. And that's the biggest thing that you'll see between us and other clinicians. We take our time in our evals, we have 60 minutes for our evaluation. And if somebody comes in and they have asymptomatic, you can x-ray your whole body, you'll find some stuff that looks degenerated. But if it's not symptomatic, not bothering you, that's not something that I'm going to work with. If somebody comes in and go, hey, how can I be preventative? There are some good studies that show that PRP can be preventative and delay progression of arthritis. So, I might throw that in there at some points if somebody's really like pushing me and they want to figure out how to be a little bit more preventative. But that's not necessarily 100% all the time. It's just something that
for sure.
So
for sure.
Was the guy's back bothering him?
It was, yeah. So I asked him, I said, is your back actually hurting? And he said, yes. And so I said, let's talk about that.
Yes, absolutely. And I would 100% say I had some body work done today. I posted that a little bit on social. And so I actually, you injected my back in Thanksgiving, and I was 60%. I've been pretty good. But getting that soft tissue work, listen, man, this is the best my lower body's felt. He got really into my hip flexors, my glute medius tendons, and really opened up my hips and my, all my core and all those kind of muscles. And that's the best. This is the best I've felt in a long time. So super pumped about that. I think we can talk about that for days, but tell me about the patient symptoms that you're seeing today. What was he having more ridiculous symptoms? Was he having axial back pain? What was he doing there?
No, it was axial low back pain. He had some degenerative discs, some facet arthritis, kind of what we typically see in somebody in that age group. Actually, his back didn't look that bad. I was kind of surprised because his knees looked terrible, but his back actually wasn't that bad. And so, we're going to do the DDD procedure on him, and he's super excited. He's got a trip coming up, so we're going to do it before then. Hey, Dr. Torrance, just real quick, I do have a question from somebody here on my side.
Yeah, what we got?
So it's Linda B972. She said I had a synovectomy and a patella reshaping, and then after I think she's saying she had a septic arthritis. Unfortunately, if I'm understanding correctly, that's terrible, Linda. I'm sorry to hear that. And now I'm asked to have a knee replacement. What do you think? So we can't obviously give medical advice to anybody online without seeing them. First of all, Linda. But first of all, it sounds like you've been through a lot, and unfortunately, this patella reshaping and synovectomy does not work. I would assume that wherever you are in the world, hopefully you're in good hands with an orthopedic surgeon that knows what they're doing. So I would always kind of defer to their advice because they're the one who can actually see you. And if you have a septic joint, that can be a real big deal and a really terrible thing. So again, I'm sorry you're going through that. A septic arthritis can really destroy your cartilage you have left in a knee very rapidly. And so it might be that you have developed like a more rapid onset worsening of your arthritis. And so again, this is a serious condition. So wherever you are, please, please, please listen to what your orthopedic surgeon says. If you get this septic part treated and you are, in the United States, or you want to have a consultation with one of our doctors by telehealth, we can look at your MRI in case, would be more than happy to do that. But a septic arthritis is nothing to mess with. So please make sure you follow your doctor's instructions on that.
And if there's any follow-up questions to that'd be fantastic. I don't think she'd be a septic joint and she'd be messaging you. Usually that comes with some systemic symptoms. So I hope that that's a previous septic joint. Again, not giving medical advice at this portion, but I think that if you are within the reach here and you want to seek out a consultation, please make sure you message, reach out to www.newregenortho.com, jump on there, or post a comment. Maybe I share a referral link. That's probably a good idea. Streaming. I'll have to figure that out, but www.newregenortho.com. I think that should post to everything. If you want to go in and fill out a candidate form, we'd be happy to possibly do a telehealth consultation to dive in further and identify what, if anything, we could do to help you. Next question. I got another question here. On the topic of PRP, I'm going to ask this question to you, Dr. Zakas. In your opinion, is PRP a good fit for every patient? And if not, what are some things to look out for?
Yeah, great questions. So nothing is a good fit for every patient, unfortunately. It is highly dependent on the condition you're being seen for. There are some conditions which are severe enough, particularly in peripheral joints, where bone marrow aspirate concentrate and a bone augmentation procedure is the best thing. So PRP may not be the strong enough weapon, so to speak, that we need. There are other people where if their platelet counts are really low, it would be unhealthy for them to donate enough blood to get a platelet-rich plasma product. And so in people that have certain anemias or thrombocytopenias, things like that, platelets might not be the best option for them either. But in general, most people don't have those conditions. So PRP is a pretty high dose concentration. PRP is a pretty good go-to for a lot of conditions. But as they get more into that moderate to severe, you're talking about your partial thickness tendon tears, sometimes some smaller full thickness tendon tears, as well as your moderately severe and severe osteoarthritis. A lot of times bone marrow aspirate concentrate is a better option. And then also sometimes some MFAT for certain tendon tears and other conditions is a good treatment by itself, or an adjunct treatment as well.
Awesome. Yeah, I don't think I could have put it better myself. I think that it all depends on what you're coming in for, what you're getting looked at for, and all PRP is not the same. And I would say that you make a very, very distinct discussion about how high concentration PRP is better and works better than somebody who's drawing 2 to 4 tubes from you. And that's the biggest thing I'll take as a takeaway here is if somebody draws 2 to 4 tubes of blood, they're not taking enough blood to get a high concentration platelet rich plasma that's going to make a difference, right? We're seeing in the literature, absolute platelet count is really where we need to go in the space. And that needs to be over about 8 billion in the knee for knee arthritis. We need to look at in tendons and ligaments. We're seeing probably about 2 to 4 billion per, like if it's a larger tendon, the higher the concentrations or absolute dosage to get the meaningful effective dose. And that's like anything. If somebody takes an antibiotic, they need to take 500 milligrams of amoxicillin 2 times a day for 10 days, right? That's the strep throat prescription. If you don't take that high of a dose, you're not going to get a therapeutic dose and you're not going to have a good outcome. It's the same thing with the platelets. That's what we're finding. You need a dose to get the right outcome. So great.
Yeah, that's like you said, that is the most important thing. We see a lot of patients that come in that had crappy PRP from other doctors before they came to our clinic. I actually had crappy PRP in the day when me and some of my colleagues were first messing with this probably, 10, 15 years ago now. And like looking back, it was probably only like 3 or 4x concentration. And there's probably a lot of red cells in it. 'Cause I remember it hurting significantly on my elbow and it did not help at all. And so I actually thought, oh, maybe I'm a PRP non-responder because there, maybe about somewhere between 10 and 15% of the population of people, for whatever reason, their PRP just doesn't work really well on them. And so I thought that was me. But then, when I joined this practice, I've had the fortune of being injected by a few of our doctors in the group with excellent results with high concentration PRP. So it had nothing to do with being a non-responder in my case. It just had to do with the concentration. The dose wasn't high enough.
Yeah, 100%. You got any more questions on your side?
Let's take a look here. So not a question, but Linda did add some context there saying she's in Martinique. She was treated already. It looks like she had a Staphylococcus aureus infection, which is Yeah, that's really difficult. Again, I'm sorry to hear that. If you're treated already and you're doing well with that, and you do want to have a telehealth consultation for one of us doctors to look at your MRI and render an opinion, we can definitely do that, Linda. Again, I'm so sorry you went through that. That's what a horrible thing to go through. We do have a question from the modern practitioner. And that is actually Whitney, who is an old friend of mine from back in the day in Arizona. And any thoughts on starting BPC 157 near the site of injury before trying PRP, or you're all in on PRP? So I'll go first on this one, and then I'd like to hear what Dr. Torrance says too. We don't always have the exact same opinions on all of these things. So right now, my thoughts on BPC 157 is I'm telling patients to stay away from it altogether. I think that, and I know a lot of people who have used this, and I believe people have the right to do with their bodies what they want to do, but I've still seen no convincing human studies that it does anything, and I'd like to at least see something before I can recommend it. And more importantly, it's still in the gray black market territory. So when you cannot get this from a reputable compounding pharmacy as it stands right now. And without that, you really have no idea what you're getting. And some people are like, they're injecting this sub-Q or intramuscular. And that worries me more than what the compound itself does. I know there is some angiogenic property to this. So one of the theories might be, could this possibly like feed tumors if somebody has them or something like that? I don't really know. I don't think any of us can comment on that because we just don't have any data. But I do feel comfortable telling people that they should not be injecting things into their bodies that are not from a licensed and registered compounding pharmacy. And I understand that, with RFK and all that, that's probably going to be changing soon. And I think maybe that's good, because I think that if people are going to take these compounds and people want them, there is a desire for them, whether that's hype or what. I don't know, but there is a desire. And so at least if people can get these from real registered compounding pharmacies, I'd feel better, at least the purity of what they're getting, that they know what they're getting and it doesn't have contaminants and heavy metals and bacteria and things like that in them. So what do you think about that topic, Dr. Torrance?
So I've dove very deep into this BPC 157, TB 500, 5000, whichever one it is. And there are 12 category 2 compounds at this point. And so what I tell patients a lot is that all of these peptides are like insulin. Insulin is the peptide that we use every day. Everybody uses it. It's well known and well tested and well thought out, right? We also use Ozempic. It's another peptide that has been 3-phase clinical trials, has been tested and proven that it does certain things. Whether we think those things are good or bad, that's a whole other conversation. But these peptides need to go through some clinical trials and make sure that they're going to do the right things. Right now, category 2 means that what you said exactly. You don't know if you're getting snake oil or if you're actually getting what the protein, what the compound is for that peptide. And so if you're injecting something in your body, it could just be an NSAID. So in my opinion, I don't really want somebody to have something injected close to my procedure that's going to possibly be detrimental to the outcome for the procedure. I'm telling people, give me at least a week on each side. And if you want to do it, that's your call, with the caveat that I don't know what it is. We don't know what it is. I know that, John down the street, man, I trust him. He's a good friend of mine. But John has no idea where these compounds and these peptides are coming from. They could be baby placentas. They could be, they could be, they could be whale urine. Who knows? And maybe whale urine has great propensity for doing stuff. Or it's like it could be, it could be, anything. So that's the problem. The problem is that we don't know what it is. And as a physician, a board certified physician at that, I cannot respectfully make the recommendation or administer this peptide that could or could not be what it is. So that's my.
And to that end, Dr. Torrance, thank you for your input there. And to that end, I don't think it's necessary. What we do, it's not magic, it's science, but it's really good science. And PRP has over 180 randomized controlled trials now. Somebody left a comment today asking me, to post the studies. And I kind of somewhat politely said, you can Google or Chat GPT and they'll pull them up for you. But we also already know what helps with healing, right? We know that, our stem cell formula helps. We know curcumin, Curcumin modulates inflammation. It does not stop inflammation like NSAIDs do. I just told a patient today, curcumin is one of the few supplements that I take every day and I'll take for the rest of my life because I believe in it. So we know that helps. We know that getting your blood glucose under control at least a few weeks before the procedure will help with the procedure. We know that aerobic exercise and increasing your aerobic exercise tolerance and VO2 max improves recoveries. So we already kind of have a roadmap for what, if anything, is needed. And a lot of people don't do any of this. They still get great results with PRP. But we also know what is really good and what can't help. And that's anything that in general improves blood flow. Sleeping is really important. Like, get your sleep before and after these procedures. And that phase 3 sleep, your deep sleep, that's when your body heals physically. Versus the REM sleep, which is more kind of psychological and brain and emotional. So getting that deep sleep is so important afterwards. The exercise is important. Keeping the weight down, reducing insulin resistance. These are all strategies we already know will help with healing from our procedures. And so we already have all that advice. I don't think peptides are necessary at this point. And if some point in the future the research on that changes and we see the outcomes are better, then I'm definitely open to opening my mind about that.
So there's a possibility that I'm going to be doing a lecture in October at OMED on this exact topic, the changing landscape, after the July meeting that's going to happen with the FDA. And there's a big meeting of the minds with all the scientists kind of coming together on this. That'll be the first step. That will not be the last step in moving these from category 2 to more mainstream and actually giving these pharmacies the actual compounding details that are needed to create these peptides. So at the end of the day, we're going to be on top of this. We'll be on top of it for you. And that's what you can expect from us. We're really on top of these peptides as well as the PRP literature. One of the best things I could tell you, Dr. Zakas, for that question that you got, go to Dr. Centeno's PDF file. If you could share that with them of the randomized control trials that he has, the little dots that you can actually click on, you can show all the randomized control trials that the person is. That's found on LinkedIn. If you're on this and you're listening on LinkedIn, jump on Dr. Centeno's posts. He's got the 2025 or 2026 randomized control trials for PRP, and he's also got it for bone marrow. And I'll tell you, the trials that are out there, or the randomized control trials that are out there, the level of evidence for PRP and bone marrow at this point, and Don Buford will agree with me on this, in regenerative orthopedics is higher than standard orthopedics. It has almost a level 2. Level 3 evidence is really what traditional orthopedics rides on at this point. And I'll say that, I'll take that to my grave. That's what we're going on. We're going on orthopedic dogma versus what the evidence-based medicine is showing is randomized control trials. And that's showing that PRP and bone marrow concentrate are the way and are the future right now. And if you haven't heard about it, you're living on a rock. So that's that. So, but listen, I think this is a good jumping point. I think it's a good night. If you need a consult, you want to come in and see one of the amazing doctors that we work with. Myself, Dr. Zakas is in Orlando. I'm in St. Peter, Sarasota. Dr. Lieber's in Sarasota. Dr. Pappas is in Tampa, and Dr. Velasco goes between Tampa and St. Pete. We do an hour-long consultation. We'll really dive into the root cause of your issues. We're happy to take a look at 1, 2, maybe even 3 places at the same time, because we want to make sure that a lot of times the back feeds to the knee, the neck feeds to the shoulder. There's a lot of things that go together that traditional orthopedics will go, well, I only do shoulders and elbows. Well, if your neck's causing your shoulder, we need to really dive in and figure that out. And these are some problems with traditional orthopedics that you have to look at the body as a whole and as a functional unit. And if they're not going to do that for you, I would just spare yourself the cost to your insurance or to yourself and come see one of us for a fantastic consultation that comes with an ultrasound-guided ultrasound evaluation and a great clinical exam and history of physical. So, Dr. Zakas, you got anything else before we hang up tonight?
Yeah, I just wanted to say that Modern Practitioner just added that she has some patients right now getting peptides from China, and it's terrifying. And that is terrifying. I don't think I need to even say anything more about that. If you guys want a consultation, all of our doctors in this group are amazing. We are not dabblers, we are specialists, and this is a big thing. And I just want to say one last thing. I actually met with my pain fellowship director when I went back to Arizona. I hadn't seen him in over 10 years.
Nice.
And so we were catching up, and he's a very well-known name in the pain field. And he's a great guy too, and has a great reputation. and a very good heart. He's doing great work out there, helping people get off of opioids, which is an amazing thing. And we were kind of talking about this, and he kind of didn't quite understand our field and thought it was maybe a little bit easier to learn than it was. And I said, no, you don't understand. You can't just take a pain doctor and tack on what we do. I said, anybody can throw PRP into a knee joint or a shoulder joint. I said, but what we do is diagnostic ultrasound. That takes a long time to learn. Learning all the comprehensive treatments for everything we do with MFAT and PRP, bone marrow aspirate, bone augmentation. This takes a long time to learn. And there's a lot of doctors out there that just try and do that as a bolt on to their pain practice. And it's not the same quality. And some of these people are great guys. Some of them are my friends, but I go to, you see this, we go to conferences and courses with some of these guys, and we're like, oh man, I would not let this person inject me. So we are specialists. This is all that we do. And that makes a huge difference.
Well, thank you for your time, Dr. Zakas. Always a pleasure chatting with you. And I will. We need to get some time for some QT and hang out, and we'll talk soon. But thank you for having me. Sure. I'm going to end my stream now. So I end your live video. So that you end your live video, I'm going to end the stream, and then I'll download everything, and then we'll chop it up and go from there. Good to see you, brother.
All right. Have a good night and a good day, everybody, wherever you are in the world. Thank you, guys. Bye-bye. Bye.